Endocrinology with MRCP Ireland and MRCPS Glasgow, FACE and DTM&H. He's a professor, Department of Endocrinology, KPC Medical College and Hospital, member of the Core Committee of Royal College of Physicians of Ireland Indian Chapter, secretary from June 2016 till date of Diabetic Association of India, more than 50 publications in peer-reviewed journals, 12 oral presentations, and 34 poster presentations in international conferences, and he's a reviewer of 12 international peer-reviewed journals, Nature publications, Springer and Elsevier, amongst the notable between them. Thank you so very much, everyone, and over to Dr. Debmalya Sanyal, and let's look at DPP-4 inhibitors in special situations along with him.
Thank you, Shomo. Thank you for the kind introduction, and I hope I'm audible.
Yeah.
Just sharing my slides.
Visible.
Yeah. So this is something very common, and as we are all aware, probably the gliptins are still, one of the safest and the easiest molecule to use in diabetes practice today. So one of the important concerns with regards to when we treat diabetes is glycemic variability or variability in glucose level. So gliptin, especially sitagliptin, decreases the mean amplitude of glycemic excursions by significantly, and this is compared to sulfonylurea, which is still probably one of the most commonest agents which we use in our practice, and this leads to definitely a reduced risk of hypoglycemia as well. Now, gliptin, among the gliptins, there is variation in terms of selectivity for DPP-4 versus DPP-8 and 9 and FAB, whereas sitagliptin is highly selective for only DPP-4. The other gliptins may not be that selective, and this may lead to increased risk of bullous pemphigoid. You can have interstitial nephritis, and we have seen certain DPP-4 inhibitors having QT prolongation because of off-target effects as well. Now, with regards to heart failure, there might be inhibition of DPP-9, which is expressed in heart, and this may impair the cardiac muscle contractility and also may cause QT prolongation as well. And this may be a probable explanation of the hospitalization for heart failure, which was increased in SAVOR-TB trial. And this may reduce the calcium ATPase in an axis, and that may reduce the calcium content in the sarcoplasmic reticulum and cause decreased cardiac output as well. And if you look at the TECOS trial, the CV safety, there was no signal of increased hospitalization for heart failure, even in patients who had high risk of heart failure, like previous heart failure, renal impairment, concomitant insulin use, and elderly population. Overall, with regards to, if you take the Carmelina, the linagliptin trials, and TECOS also into consideration, the effect of DPP-4 inhibitor on heart failure remains neutral, no significant increase or decrease. Now, with regards to patients having prior heart failure at baseline, gliptin, especially Sita and Lina, had no worsening of heart failure, even when we are using these agents. And this has come into the guidelines as well, where these are the two gliptins which can be used in cardiovascular disease and especially in heart failure as well. Whereas if you look at, MACE, the MACE outcome is almost similar with all gliptins. It's neutral. Only in the SAVOR-TB trial, we had an increased risk of heart failure, hospitalization, and also there was a signal in examined with allogliptin. But especially with TECOS and Carmelina, that is Sita and linagliptin, there was no signal of increased risk of heart failure as well. Now, with regards to QT prolongation, obviously there is a worry with use of when we are using teneligliptin, even when we are using especially approved doses like 80 milligram as well. So we should be careful in patients who have hypokalemia, ischemic heart disease, bradycardia, or even hypoglycemia, which can beget the QT prolongation. Now, we are all aware during hypoglycemia, gliptins increase glucagon, and during hyperglycemia with meal, they decrease glucagon level. And that's why gliptins, when they are used along with insulin, and this has been approved by most of the august bodies, including ADA and AAC, they actually decrease the risk of hypoglycemia compared to using insulin alone, probably by increasing the glucagon during the time of hypoglycemia as well. Now, when we are using several agents like ketoconazole or which prolongs the duration of action of saxagliptin, increasing risk of hypoglycemia, and similarly rifampicin, which decreases the effect of linagliptin, there is no such effect with sita and vilda. And mainly, sitagliptin has a renal excretion, whereas linagliptin has a biliary excretion, and vilda and saxa also have a primary renal excretion, whereas teneligliptin has both almost equally distributed. With sitagliptin, even 25 milligram doses in ESRD and dialysis patients, they provide similar HbA1c reduction, especially 0.72%, compared to moderate or severe renal impairment when you are using 50 milligram, or with mild renal impairment when you are using the full dose. So even in ESRD patients, we have a significant reduction in HbA1c with a minimum dose, that is 25 milligram, which can be a really significant cost saver as well. And there might be some effect with regards to reduction in albuminuria. And sitagliptin had shown in the TECOS trial to have stable EGFR over 4 years, something which was also shown in some of the linagliptin outcomes trial as well. Gliptin in NODAT, there is data with regards to sitagliptin, which showed a significant HbA1c reduction with no significant change in EGFR. We have also published data with linagliptin as well. And with regards to non-glycemic effects, they have neutral effects on CVD and neutral effects on EGFR in patients with CKD with modest albuminuria reduction. With aging, there is a gradual decrease in GFR, which is aggravated in diabetes patients. And all three doses are equally effective in elderly with reduced renal function as well. And in elderly, compared to very elderly also, sitagliptin remains a very effective agent, even in more than 75 years. So this is really with regards to ease of use and safety of use, this is a preferred agent, one of the most preferred agents in elderly population, and also its renal safety. With regards to hepatic impairment, with regards to mild and moderate, this agent can be used, as can be lina and saxa, but vilda and teneligliptin especially, we should be careful. And we are all aware that in NFLD, the DP4 activity is raised, and there is an elegant study showing that with sitagliptin use for 1 year, hepatic and the liver histology was significantly improved in terms of steatosis, ballooning, and inflammation. And also, there was some improvement in the fibrosis score as well. So this may be an upcoming indication as well, especially in patients with non-alcoholic fatty liver, where you can use even in mild to moderate hepatic impairment as well. Now, pancreatic safety, especially no signal of pancreatitis or pancreatic cancer. With regards to fracture risk, this is so very common with certain diabetes medications, especially thiazolidinediones, and even to some extent SGLT inhibitors. GLP-1 have neutral effects, whereas with DP4 inhibitor use, there is actually benefit in terms of reduction in fracture risk with DP4 inhibitors. So this is something really beneficial, especially in elderly. Again, postmenopausal, there's a reduction in fracture risk, which is so very common with osteoporosis. Now there is data, especially in non-critically ill hospitalized patients, along with basal insulin. We do not require a basal bolus insulin. Gliptin, especially sitagliptin, the Sita hospital study showed that along with glargine, they were effective in terms of providing reasonable control in non-critically ill hospitalized patients. But we require further data. It's still not officially approved in this hospitalized population. And there has been some data, especially with benefits in psoriasis. There can be improvement in skeletal muscle mass and decreased risk of fall as well. And there can be improvement in cognitive function. So in elderly, especially those who have cognitive dysfunction, minimal risk of hypoglycemia, minimal risk of fall, and maybe some improvement in cognitive function as well. And some probably effect in terms of progression-free survival in advanced airway and colorectal cancers as well. So gliptins, because of its safety, minimum side effects, and effectiveness in variety of population, so they are really one of the agents which are preferred, and that's why their treatment to They have the highest treatment adherence as well compared to other agents, and there is least amount of discontinuation. But there are some caveats which we must, because in this gradually we are going into a generation of precision medicine. So probably patients who have obesity, high triglyceride may have a poor response to DPP-4 inhibitors. So with regards to the available gliptins, probably the highest amount of publications are there with sitagliptin, and it's approved in all major markets, and there are future prospective trials also going on with these agents as well. And probably the least amount of data we still do not have enough data with teneligliptin. So when using gliptin in special population, the most important thing which we have is safety, and that's the reason why it is a preferred agent in treatment of diabetes population in diabetes patients with various category of patients. Thank you very much, and I would be happy to take any questions.